viewers, welcome to Gyan Pravah Series, episode 86, which has been conceptualized by our visionary and dynamic president, Sunita Tandulwadkar Madam. Today, we have a guest who is a legend, not only in urogynecology, but innovator, filmmaker, and philanthropy, Professor Ajay Rane. Let me introduce first Dr. Sunita Tandulwadkar Madam, who is president of FOGSI, a body of 46,000 gynecologists. She is director and HOD of IVF and Endoscopy Center, Ruby Hall Clinic, Pune. She is founder and medical director of Soul Clinic IVF, a center for excellence in infertility. Madam is co-founder and medical director of ELI, a stem cell research and application center in Pune. She is the recipient of so many awards, including Appreciation Award from the President of India. Madam has been innovating many things to implement for the well-being of the common people and engaging all of us in many projects like Sampurna, Know Your Number, Do Tike Jindagi Ke, and many more. Her slogan, Ek Rashtra, Ek Mission, Swasth Nari, Samridh Vachan, is really to keep our women healthy and disease-free. Today, we have Vice President Dr. Ava Singh on behalf of her because she is busy in other meeting. So, Madam will introduce and she will bless us. Madam Ava Singh is very busy, very active, HOD of Lady Gynae Department in Lady Harding College, and always guiding us and directing us to do the best so that our committee and our FOGSI will have good names and will do for the people, common people who are suffering from many problems in our country. So I request Ava Madam to bless this program, and then I will introduce Ajay Rane sir. Madam.
Okay. Thank you, Dr. Kavita, and good evening, I should say, to Dr. Ajay Rane also, who's a good friend of mine from last many years, and I know him as a big famous urogynecologist practicing in Australia. So thank you, Dr. Kavita, for your generous words. At present, I am working as Professor Obs and Gynae at ESI Medical College, Faridabad. I have superannuated as HOD from Lady Harding Medical College. So that is something which I should say because people are still confused. And you know, this Gyan Pravah is conducted every night at 8 p.m. by one of the committee chairpersons. 30 chairpersons are doing this podcast every night on the same date every month. And on 31st, the president, Dr. Sunita Tandulwadkar, she takes that podcast. Gyan Pravah or flow of knowledge occurs every night at 8 p.m. and the chairperson invites some eminent personality from any field they want, like cricketer, politician, spiritual leader, NGO, policymaker, or any achiever in their field. Even obstetric and gynecologists of eminence are taken. And all the chairpersons, they are doing fantastic job on each day they are on which it is allotted to them. And all of us, they gain in-depth knowledge of that subject. And you will be surprised to know that there are 3,600 FOGSians who will be watching this program at different platforms. So today, Dr. Kavita Barnwal, chairperson of Urogynecology Committee, FOGSI, will be having a dialogue with Dr. Ajay Rane on an eminent urologist from Australia. So thank you, and let us all join this podcast. And the protocol is that Dr. Kavita and Dr. Ajay will do the talking, and we will just listen from another link. Thank you.
Thank you, Professor Abba. Nice to see you again. And we hope to see you at FOGSI in Delhi.
Yeah.
Wonderful.
Yes.
And I'm having a VP conference in Noida a few days back now.
Let me know. Let me know.
Okay. Thank you.
Thank you, madam. Thank you so much. So it's my pleasure to introduce the guest speaker of today, Professor Ajay Rane sir, who needs no introduction. He is Director Urogynecology from Sir has been awarded Order of Australia in 2013 for work in women's health and finalist Australian of the Year in 2012. Sir has received Mahatma Gandhi Pravasi Award in 2016.
We have an internet issue.
Professor Ajay Rane Public Service Medal in 2022. Sir is also a filmmaker and made film Riayat against a very budding topic, that is female infanticide. He is innovator in pedigree, Dungy epiziometer, peritable, and philanthropy like Dignity Sanitation India, Flourishing Women in Pacific, Asia, and Africa. Sir has authored more than 7 books and written 52 chapters and more than 188 peer-reviewed papers. So I think Sir's introduction is very small as he deserves. But overall, Sir is very humble, very spiritual. Whenever we call him, he always ready to be with us and to give important and useful tips related to urogynecology or any other thing. So, Sir, before I start, I request you to introduce yourself.
Thank you. Thank you,
This time
Kavita.
we're in Australia, but can you, can you introduce, Sir?
Thank
Yes.
you. Thank you for your kind invitation, and thank you to President Sunita Tandulwadkar, of course, Professor Abha Singh. I would like to take just a moment to remember the unfortunate, sad victims of the shooting that took place in India. And it's a very, very sad thing. So I would just like to take a moment to pray for them and hope that their souls rest in peace. So we'll just be quiet for about 5 seconds. Thank you. Thank you. Introducing myself is not important. What is important is what we are going to discuss. I think the important part is that there are many people like me who do urogynecology. We have a different take on this subspecialty because we basically concentrated our subspecialty services to people who are poor and who are difficult to reach. And that's the part of urogynecology that mostly youngsters don't want to do. Things like genital trauma, fistula, it's not glamorous. It's not robotic surgery. It's not laparoscopic surgery. It's something that you will find much more common in interiors, or it could be also in areas where health accessibility is poor. So thank you, Dr. Kavita, for introducing me, and thank you for asking me to introduce myself. But really, it's more about your wonderful nature. You've been head of Urogyne for FOGSI. It's been great to interact with you. So we are ready for another interaction, Dr. Kavita. So let's go.
So thank you, Sir. So, Sir, why it is important for every gynecologist to learn urogynecology?
So I think urogynecology has been made into a subspecialty, but I think the bottom line is, like I said before, the biggest issue that people don't understand is anatomy. The anatomy is very obvious. The genital tract is sandwiched in between the colorectal tract and the urinary tract. So the genital tract is actually very closely related to the lower urinary tract and the lower gastrointestinal tract. So because sexuality is done through the genital tract, childbirth is done through the genital tract, menopause is affecting the genital tract, but it also affects the lower urinary tract and the lower gastrointestinal tract. So everybody needs to know, it's not urogynecology, everybody needs to know that there is this intimate relationship between the bladder and urethra, the vagina and cervix and uterus, and the anal canal and rectum. Very intimate relationship. So in a way, when we started doing urogynecology, I had to do urology, then I had to do colorectal surgery, then I had to do gynecology. But for me, I think now it is very important that it's very hard for people to do 3 subspecialties in a career. It's a very long studying process. So more importantly, we should teach everybody that this is a very intimate relationship between the lower urinary tract, the genital tract, and the colorectal tract. That I think is why I think everybody should know about urogynecology, because it is inevitable. You are going to see the problems of following childbirth. You are going to see the problems during menopause. And you have to be able to at least do the basic understanding investigations so that these women are not left on their own just because there's nothing surgical to be done. So it's very important to understand that. So I hope that answered your question.
Yeah, thank you, sir. Sir, can you explain what are the different aspects of urogynecology? I think urogynecology you have well explained that is related to both the roots. But can you say that what are the different aspects of urogynecology? Because it's a vast thing.
Yes, so urogynecology technically has always been, it has been publicized as a surgical subspecialty. But in my opinion, 60% of the cases we see actually don't need surgery. So it's a very large subspecialty that covers urinary systems like urgency, frequency, nocturia, stress incontinence, urge incontinence, true incontinence due to fistulas, painful bladder syndrome, recurrent urinary tract infections. Then we can go into the genital tract and look at genital prolapse, cystoceles, rectoceles, uterocervical prolapse, enteroceles, patulous genital hiatus leading to sexual dysfunction, also dyspareunia, usually due to levator spasm or due to iatrogenic surgery causing dyspareunia. And then we move into the colorectal system where we have got rectoceles, you got rectal intussusception, you got obstructed defecation, and worse, you have got fecal incontinence or flatus incontinence following childbirth, or sometimes even following colorectal surgery. So very vast subspecialty. But I think if I can put this simply, my current PhD student is working on the topic, put me out of business. So I challenged him to say, can you do a PhD on preventive urogynecology so that you can put me out of business, And it's wonderful to see what work he has done. And it is quite possible for us to prevent nearly 35 to 40% of pelvic floor disorders, especially following childbirth or following menopause. So I think preventive urogynecology is as important as therapeutic urogynecology, which involves either giving medications or doing surgery or doing physiotherapy or using pessaries, etc.
Thank you, sir. So, what additional aspects can urogynecology offer in women's health?
So,
what do you think? What are the additional aspects which can
I think
offer in women's health?
Yeah, so our take on that is we should really be the people who need to look after either very complex genital prolapse, for example, recurrence, okay, not primary prolapse. We should be the people who should be looking after urinary incontinence, complex urinary incontinence, not simple stress incontinence. That also should be done by the local doctors because the problem is so big, you can't have enough urogynecologists. So we should be looking after complex urinary incontinence, complex prolapses, recurrence maybe, or very short vagina, complex fistulas, vesicovaginal, ureterovaginal, or rectovaginal, anovaginal fistula that are complex. Someone has tried to repair it, hasn't worked, then they need to be referred. So these are the additional things that should be our primary job. Our primary job should not be doing the straightforward cases. I believe as a subspecialist, you should be open for your colleagues to send you complex cases. They have tried. Unfortunately, some of it hasn't worked. And that is the role of a super specialist or subspecialist. It is not to say, ye kya kaam kiya, acha nahi kiya. It's not that. The role of the super specialist or subspecialist is to take on the complex cases, to say that you have a complex problem, and it probably that is the reason why it hasn't been solved totally to your satisfaction. So that is why you are here, and we will look after you. It's not to put blame on the primary surgeon, but more importantly, to explain to the patient that because it's complex, that's why you're seeing me. If it was simple, I would not see you. Now, I think that sort of mentality, attitude will take time. It will take time, but I think it will happen.
Thank you, sir. So just now you mentioned preventive urogynecology. So can childbirth trauma and pelvic floor dysfunction be reduced? So what do you think?
Absolutely. Yes. My 30% of my publications are on preventive urogynecology. So let us just for a minute think about what part of childbirth trauma can we reduce, okay? So we will start with something very simple like obstetric anal sphincter injury. So OAC, or obstetric anal sphincter injury, occurs in between 3 and 4% of women. But the biggest problem is sometimes it is actually not diagnosed. Every time a woman gives birth, we do PV examinations, but somehow we're very scared to do PR examinations. You have to do an anal examination on every single patient because you can still have an intact perineum but a disrupted sphincter. So a lot of people think that an intact perineum means sphincters are not gone. So you must be able to do an examination. That's number one. Number two is we have just published with the help of Professor Gauri Dorai from Pondicherry, one of the largest randomized control trials in the world. This is from India, done by her, to show that if we give a timely episiotomy in women who are giving birth, you can reduce obstetric anal sphincter injury by a factor of 40%. Just a simple episiotomy given correctly with a little protractor called the episiometer. It's just a piece of paper, costs 20 paise. You can cut along 60 degrees, 4 centimeters. But such a simple maneuver can reduce your obstetric anal sphincter injury rate by 40%. So preventive urogynecology oasis, okay? Let's take the next important part, which is stress urinary incontinence. Stress urinary incontinence occurs again due to damage to the pubourethral ligaments because the pressure during childbirth has been transferred from the posterior compartment to the anterior compartment. So again, we have done research to show that if we reduce the second stage of active pushing to 60 to 90 minutes only, again, if we allow a timely episiotomy to allow the compartment to expand rather than break the tissues anteriorly or posteriorly, you can reduce stress urinary incontinence by 35%. So preventive gynecology is all about simple things like making sure that you do a hands-on delivery, making sure you give a timely episiotomy to prevent oasis, making sure that in the anterior compartment you have paraurethral stretching or tearing, then it's time to give an episiotomy so that you can prevent anterior compartment trauma. This is the simplest thing one can do. So 3 things I have talked about. One is hands-on delivery. Second is timely episiotomy. Third, 60-degree angle, 4 centimeters. You will reduce both anterior and posterior trauma, and you will reduce oasis, and you will reduce stress incontinence. Now, the question of uterocervical prolapse, I am hoping that the process of bundle pressure has stopped, because that was a very dreadful thing people used to do, fundal pressure, when the woman used to be in the second stage of labor. That actually causes tearing of the uterosacral cardinal ligaments. So uterocervical prolapse occurs predominantly in women who are actually subject to fundal pressure. So who don't do fundal pressure. I don't think it's done a lot, which is good. Then I think the important part is pelvic floor rehabilitation post-delivery. So it's very important that the women themselves feel such a big baby has come out of my genital tract. They think, oh my God, it's all destroyed. It's all torn. You know, it's never going to be the same again. Completely wrong. We have to explain to the women that there is a wonderful process that God has put into place called tissue remodeling. The vagina stretches to 6 times its normal diameter when you give birth, but it doesn't stay that way. It comes back through tissue remodeling. And tissue remodeling is very, very important concept, which we have done a lot of research on. Because again, tissue remodeling tells us that when you do prolapse repair, don't cut too much vagina, because you will not get tissue remodeling. The vagina becomes very, very small. So you should allow tissue remodeling after you've repaired the prolapse. And prolapse repair is not about vagina. Prolapse repair is the tissue behind the vagina. For example, uterosacral cardinal ligaments for the uterus, and fascia, rectovaginal fascia posteriorly, and pubocervico-vesical fascia anteriorly. So once you've done that repair, then the vagina, don't try and cut it too much, because it does not allow tissue remodeling. Tissue remodeling also occurs even in 90-year-old patients. So it's a wonderful thing. The vagina is an amazing organ. Last bit of preventive urogynecology is treating women in the perimenopause and the postmenopause, especially with topical estrogen. Topical estrogen is very important to prevent urinary urgency, frequency, irritability, vaginal dryness, sexual dysfunction. Again, the same important thing is do not wait till they become symptomatic, but actually prevent it by making women understand that menopause is a natural process in life, but 20 to 30% of women will suffer from lower urinary tract symptoms, and these are amenable very easily to treatments like topical vaginal estrogen, cranberry tablets, etc. I hope that answer was to your satisfaction, Dr. Kavita.
Nowadays, more women are living in postmenopausal age group because of increased life expectancy. So, as a preventive aspect, can all women should undergo cesarean section to prevent injury to the pelvic tissues?
I know you would ask that question. Yeah, we have done a lot of research on this. And one of the biggest studies that we are involved in is called the PROLONG study. PROLONG study is a 20-year study of a woman's life. The PROLONG study and another study called the SWEPOP study very clearly shows that there is no benefit from an elective cesarean section as far as urinary incontinence is concerned, as far as fecal incontinence is concerned, as far as sexual dysfunction is concerned. The only advantage you may have in 20 years is a protective effect against genital prolapse, but it's only about 5 times. So yes, an elective cesarean section may protect you against genital prolapse, but against nothing else, not against stress incontinence, urinary incontinence, not against fecal incontinence, not against sexual dysfunction. So the mathematics is you have to do 9 unnecessary cesarean sections to maybe prevent 1 genital prolapse. So absolutely not. Women should not have an elective cesarean section for preventing pelvic floor disorder. If you want to prevent pelvic floor disorder during childbirth, please, please, please restrict your second stage to between 60 and 90 minutes, do a hands-on delivery, give a timely episiotomy, and you will absolutely protect these women from childbirth trauma. If you're able to do that, then you can also deliver my daughter. But if you are not able to do that, then I would tell my daughter she should have an elective Caesar. But this is wrong. You know, why aren't we able to do a hands-on delivery? Why aren't we able to give a timely episiotomy? All these fashions that have come up that have really increased our pelvic floor trauma rates because we have allowed extremely prolonged second stage of labor that causes pudendal neuralgia, pudendal neuropathy even, because anything more than 90 minutes increases your risk of pudendal neuropathy and neuralgia. And also somehow episiotomy has become a bad word. If you give an episiotomy, you're supposed to be not a very good obstetrician. And not performing hands-on delivery or doing a PR examination after childbirth, then why are you there? My question is, why are you there? You know, you're not just there to light agarbattis and sing songs. You're there to actually help the woman to prevent pelvic floor trauma. And that is the reason why I feel no woman should have an elective cesarean section to prevent pelvic floor trauma. Very clear message.
Okay, sir. Yeah, clear message. Thank you, sir. So, sir, what is the global aspect of urogynecology? What do you think?
The global aspect?
Yes.
Well, my life has been spent doing urogynecology globally. So I will just tell you in brief what our footprint is in 4 major categories. First category started with childbirth fistulas. Was it urinary fistulas, rectovaginal fistulas? We worked with FIGO. We trained a lot of surgeons. We worked in Africa. We worked in Bangladesh. We worked in Nepal. We worked in the Congo. We worked in various countries where fistulas are prevalent. The important thing about fistulas is the 3 Ds: delay of diagnosis, delay of transport, and delay of treatment. India is quite fortunate in that sense. We are almost not seeing fistulas in India. But the truth also is that we have really trained so many surgeons to treat fistulas, but more importantly, we've educated surgeons and midwives and health workers about delay of diagnosis. So no woman should see a sunrise and a sunset in labor. Very simple message. Sunrise and sunset she should not see. If she has seen a sunrise, by sunset, if there is no baby, you need to start moving that patient. Somehow find a bullock cart, find transport so that the patient is actually transferred to somewhere where there is medical help. And then that's the second thing, delay of transport. And the third thing is delay of treatment. So these women definitely need either an emergency cesarean section or they need a vacuum delivery. Something needs to be done. But once you get that message through, the incidence of fistula goes down, and it has gone down tremendously, and which is wonderful news. And UNFPA is now saying that the world should be fistula free by 2030. So that was our first footprint from a global point of view. Quite successful. Our second footprint was, as you mentioned, female infanticide and feticide. That is also a female trauma. So in 2009, in the Lancet, there was a paper published that India and China alone are responsible for the death of 110 million girls, either before birth or during birth or after birth. 110 million. That is a very, very large number. Very large number. And so what it did in the process was change the gender ratio. Normal ratio is 1,000 women to 900 males. Completely reversed it in a lot of states in India. In China, it was the same. One-child policy meant they wanted boys, they didn't want girls. So these girls were being killed either in the uterus when they were pregnant or after birth. 110 million is a very big number. Fortunately, we ran this program. I made a Bollywood movie, as you said, Riwayat. It was very successful internationally, not a big success in India because, again, when you show your own weakness, people don't want to see it. But it started under the kind guidance of Prime Minister Modi, who I had the pleasure of meeting on January 9th, the Beti Bachao, Beti Padhao program. And what has happened now, China has stopped the one-child policy. We have got the PNDPD Act, which is the Act of No Gender Diagnosis and Ultrasound. We have the Beti Bachao, Beti Padhao program. And so female infanticide and feticide has gone down by 75%. And that's wonderful news for women. So again, our second footprint globally brought a big change in protecting girls from being killed. The problem is we have killed so many girls since 1984 that the gender ratio to become normal is going to take another 20, 30 years. So now we have a whole group of young men who don't know how to behave with women. So unfortunately, because of that, there is a lot of incidences of female gang rapes, genital trauma to women. And that is the ugly side of the third footprint that we have. Our third footprint is about traumatic genital fistulas. I have been fortunate or unfortunate to look after some very famous cases in India who had suffered massive trauma through gang rape. And it is a very, very sad situation. To even think that men can do these things is very, very scary. I am going to continue talking. So genital trauma, traumatic genital fistulas are very, very global. They are very high in Congo. They are very high in a place called Papua New Guinea. They are also very sadly occurring in India. So that's the global footprint of traumatic genital fistulas or traumatic genital patients. And I don't think we have made a big reduction in those numbers, even though we have been working in this space for the last 20 years. But we are working hard. We're making people aware. We even got a Nobel Peace Prize for that in 2018, 2019. So these awards help us to tell our story about what women go through. Unfortunately, they have gone through similar trauma in war, happens in Ukraine, happens in Syria. We went to Mosul, happens all over the world. It's very, very sad. Women are always traumatized where there is war. So, and the last footprint is female genital mutilation or female circumcision. Now, the sad part about it is that female genital mutilation or circumcision is still practiced in India. And Insia Dariwala is an amazing person from Mumbai who is the champion who is trying to stop this process, especially occurring in the Bohra Muslims. So female genital mutilation is cultural. It is not religious. So it was done by the Christians, the Jews, the Muslims. It's a cultural issue. It's not a religious issue. But our plea is that we want even that culture to stop. There is no culture that should promote the cutting off of females' genitals between the age of 5 and 9. There is no culture at all. No religion tells you to do that. No culture tells you to do that. So we have done a huge education program on female genital mutilation and female circumcision. And I am told that it has actually reduced considerably in the world to the tune of between 50 and 60%. So global urogynecology, Dr. Kavita, as you asked, it's our blood, it's our life, it's our heartbeat. But the stories are actually of good news. You can see that we have made a difference. Thank God we have made a difference. And we are very passionate that we want to continue to serve these women so that we can reduce this trauma even further. I'm sorry I've taken a little longer to explain global urogynecology, but I think it's important to understand.
Yeah, exactly, sir. So really, you have raised these points, and it should go to public that this type of genital mutilation and these things should not be considered in any religion, in any group. So this
Absolutely.
is yeah. So, sir, what do you think about the future aspects of urogynecology in India, and how can we train better in India for us? Because we are really, when we are in students like BBS students, PG students, we're not taught urogynecology. Now it's coming to be in the emerging plans. So what do you think? What are the future in India?
Well, I think personally, I think the future is good, and you are a classic example. So when I came to India in 2001, there was no such thing as urogynecology. Professor Rajamaheshwari was the urologist and the gynecologist, so probably one of the true urogynecologists in that country. But it is 1.4 billion people. So I think there is a big change for the good. That's number one. People are talking about urogynecology. Finally, they are actually accepting that there is such a thing, not just infertility and IVF. There is actually something called urogynecology, which is quite important. I think the next important thing is India has been blessed, and truly blessed, by excellent vaginal surgeons. They are very, very good, competent, amazing vaginal surgeons all over India. Wonderful. I can name at least 50. But, Shirish Seth is one who obviously comes into mind. He's 85 or 86, still going. I won't be going, but I'm just saying that amazing vaginal surgeon. Harapat Naik, all these guys who are promoting vaginal surgery. So vaginal surgery has been a very big stronghold of India. We should not lose that. Somehow we are losing that battleground to laparoscopy and robotics. It has its place, but it's not primary surgery. So I think that knowledge base should be used for reconstructive urogynecology, because if you're a good vaginal surgeon, just to remove the uterus or suspend the vagina, you could be a very good vaginal surgeon for genital prolapse as well. So we need to harness that energy and that skill of vaginal surgery. The third important thing is, I think that if we demystify urogynecology, that, oh my God, it is something big, rather than that, we say, look, it's the basic need of every woman. Because really what is associated with urogynecology is childbirth and menopause. So you cannot run away from childbirth and you cannot run away from menopause. So we should be teaching a little bit more on pelvic anatomy, the effects of childbirth, effects of menopause on the urogenital system. And then the complex issues, they can be referred to a subspecialty. So after people do their postgraduate, whether it be DNB or MD, they can maybe do a year in a urogynecology setup to see how the complex things can be done. But I think basically our training volume is amazing. The students are very intelligent. I just feel that we should keep pushing that message of learning about pelvic floor anatomy, again and again and again, and then applying that to assessment. But forget the treatment for 1 minute. But you should be able to do a good assessment of a urogynecological problem, good history taking, good examination, and then deciding. There's no such thing as a mild cystocele, mild rectocele. We never ever allow such diagnosis anymore. Basically, if you part the labia and ask the woman to strain at maximum Valsalva, the bulge should come out of the hymen. That is a prolapse. Otherwise, there is no prolapse. So I think it's very important to stop this mild. There's no mild. Absolutely not. So we should be able to teach in our postgraduate curriculum excellent skills of history taking and assessment. And then you can do good treatment. If you don't do a proper assessment, if you don't take a proper history, how can you do a proper treatment? So my plea is that in the undergraduate and the postgraduate, we should have that in the curriculum, and then the rest will follow. But I think having now been in this field for more than 30 years and having been to India every year of my life, I think the future is very good. And it is in the capable hands of yourself and Professor Abha and others. It's good. It's good. We should promote it.
Thank you, sir. Thank you. Sir, you had made a film, yeah, just now you mentioned, against a very sensitive issue, infanticide. So what instincts you had to make this film? How you thought to make this film, Riayat?
Oh, thank you. Look, it is very important to understand that we're human beings. We are fathers, brothers, husbands, and the women are wives, daughters, mothers. And so when I read this article in the Lancet, which said 110 million girls have been killed in India and China alone, we said, why doesn't the world know about this? Why is it that anything that relates to women usually never comes out in the news? So 110 million is the world's largest genocide. It is the world's largest genocide based on gender alone. So we looked at education, we produced a documentary, and it had no impact. We were not making an impact. So Professor Sanjay Patole, who is a professor of neonatology in Perth in Western Australia, very, very good friend, he suggested, why don't we make a Hindi film? And, you know, always when you think outside the square, outside the box, it's very exciting. So I thought, yeah, okay, well, if we do this, what will be the impact? The impact was amazing, because really it's the only way you could tell your story to the common person, that the doctor is not wrong, the dai who kills the baby is not wrong, the mother-in-law who forces the daughter to have an abortion is not wrong, the poor woman who has conceived the baby is not wrong, the husband is not wrong. It's society that's putting this pressure. So we have to change the society's attitude towards female infanticide and feticide, because, you know, Amir Khan made that little thing and where he was blaming doctors. Nobody is to blame except society. We are the people who have decided suddenly that males are more important than females. But hang on a second. You want to have a wife, but you don't want to have a sister? You don't want a daughter? How is that possible? It's impossible. So I think the education was about not blaming one profession or one type of person or one type of family, the rich, the middle class, the poor, the dowry system. It is the culture, it is the society that needs to take responsibility. So our movie was about actually saying, none of you are individually to be blamed, but you are pushed into that circumstance. And that, I think, suddenly people realize that That is the correct way to look at it. So I think once you realize that, then people don't do bad things, they don't do illegal things, because they know that, it's not just me, it's a societal pressure. That is the reason why we moved into this female infants and feticide. And thanks to Prime Minister Narendra Modi, the Beti Bachao, Beti Padhao program is very successful. And we're so proud that, we are trying to make a difference to women, not only in India, but all over the world through this. So wonderful news.
Yes, now both the central and state government are working to these things like Beti Bachao, Beti Padhao Abhiyan. Even our state government, they are giving money that birth of the girl child.
Wonderful.
So these things will motivate them. Just yesterday, result of UPSC came, and the topper is Mrs. Sakti Dubey. She is from Prayagraj. So now things are moving, and women are getting forward and taking highest post. So really, thanks goes to government, and thanks goes to you also, the people like you who are motivating all these things and are making films to sensitize the people. So, sir, you are an innovator and great philanthropy. How these things you could do besides medicine? So I know you are very busy, but still you are doing so many things to sensitize the people to do these things. How do you do, sir? How do you get the time?
I think the most important English saying is, if you want something done, always ask a busy person. But I think really more importantly, we are all caught in the race. We're all caught in the race of success. We're all caught in the race of career. We're all caught in the race of financial security. We're all caught in the race of raising a family. And that's completely normal. I have been through the same race. But time and time again, you look at some of the victims of childbirth trauma, acute genital trauma, and you suddenly realize that there is a bit more to life than bigger house, the bigger car, the more expensive suit. So you realize that. But once you realize that, then you say, how can I help these people? And we said, okay, 2 weeks out of a year, only 2 weeks out of a year, we will give for free. We will try and help these people. We'll do it for free. We will treat them for free. We will travel for free. And very quickly you realize that actually you are not giving to them. What you get back is far, far more exhilarating. It is so wonderful, the feeling you get, that you actually then increase the 2 weeks to 4 weeks, then 4 weeks to 6 weeks. And more importantly, then now I do about 3.5 months of charity work all over the world. But more importantly, you get blessings. You get blessings from the victims. You get blessings from your colleagues. And so I end up with an amazing team. I've got a team of 6 doctors. They are all like-minded. I have Dr. Jay Iyer, who is an amazing, amazing surgeon. Now I have got Dr. Usama Shahid. We have got Dr. Natasha. We have got Dr. Grace. So they are from all over the world. They are from Pakistan. They are from India. They are from Australia. They are from England. And we have got this wonderful team. They are from Africa. And I think that these people are so committed as well to helping the whole cause that our 4 months is now becoming nearly like a year-round process, because all of them are also helping. I'm doing 3.5 to 4 months, but they are also helping. So we have this wonderful time in life now in the last 4 or 5 years where we are actually able to give round-the-clock philanthropic service free of cost. We take instruments, we take suture materials, we take different types of instruments, etc. We leave it there. We operate and we leave. So very, very blessed to serve these wonderful women. We just came back from Nepal. Wonderful place to help, and we are actually feeling now that we are not helping. They are actually blessing us, so we get more out of it than they do. It's a different attitude as you get older when you see and do so much. So for me, I'm blessed that we met Her Excellency President Draupadi Murmuji and Prime Minister Narendra Modi ji on the 7th and 8th of January. And they gave me the Pravasi Bharatiya Samman Award, the highest civilian award that a non-resident Indian can get. It's a blessing. It's not a recognition. It's a blessing because, I always say that it gives us an opportunity again to tell the stories about women, because we tell the story and their eyes go up and they go, we've never heard of this before. So we need to tell the story about the sufferings of women, that what they go through globally, and how we cannot afford to avoid it anymore. We have to tackle it head on, whether it be through women empowerment, whether it be through no violence to women, whether it be through Beti Padhao program. Every single bit will make a difference.
Yes, sir. Thank you so much for the wonderful message that we have to do something for the poorer community. And really, we will get the blessings, and that will be reward from God also. So thank you so much, sir. Yeah, and you have been awarded so many things like Order of Australia. So what's your reaction? By Government of India is Australia. So what's your reaction? Just now you mentioned so many awards. So what is
yeah, you read the list of awards. I know
much more than this. Yeah.
You read the list of the awards. I think the next award is coming in June from King Charles. Look, I think the awards only mean that we are hoping to increase the awareness of female genital health, female pelvic health. I'm very grateful for the awards. Please don't get me wrong. But we use the awards as a platform for the voice of women. I accept this award not for myself anymore. First award, yes, I think, oh, yes, you're doing a very good job. Now, no, yes. I don't accept these awards at all for myself. I accept them on the behalf of the women who have blessed us, who have given us the opportunity to serve them. And we have to keep telling their stories so that the world will realize that gender-based genital violence, fistulas, female genital mutilation, infanticide, etc., is a truly global problem, and that we need to be aware of it. In fact, even simple things like stress urinary incontinence, genital prolapse, it can destroy women's lives, their personal lives, their sexual lives. And if you're not aware, then we are really doing a disservice to women. So thank you for your question. The answer is I really humbly accept these awards on behalf of the women I represent. And I'm very proud to be a male to represent women, because that is another critical issue that I'm very strongly passionate about. You don't need to be a female. You can be a male or a female as long as you have the right passion and the right direction and the right attitude. Then you can represent women and be blessed by the ability to represent women.
Thank you, sir. There are so many questions like use of laser energy sources in urinary incontinence. How can you differentiate the story symptoms, body symptoms? Just tell in a few sentences, what is the best way to treat SOI, like slings or the newer things which are going to be tapes? So what do you think, sir? Just you mention in one or two sentences.
I think, like I said before, We can keep it very simple. We only got 3 minutes. So let's keep it very simple. Basically, you have got the bladder as a storage organ and the urethra as a sphincter mechanism. The sphincter mechanism usually breaks in childbirth, and or the sphincter mechanism can become weak during menopause. This will purely lead to stress urinary incontinence, which is leakage when you cough, laugh, sneeze. Okay, they can be very complex types of stress incontinence, but bottom line is 70 to 80% of women, if they say, I leak when I cough, laugh, sneeze, then most likely they have simple stress urinary incontinence. And if they are in the childbearing age, then initially 16 to 20 weeks of targeted pelvic floor exercises, either by a physiotherapist or a nurse, helps a lot in more than 60% of patients. The other 40% who don't get better should be referred back due to failed physiotherapy. And these are the women who would benefit probably from some kind of anti-incontinence procedure, be it a sling or be it a Birch-Goldberg suspension. And then there is that small group of patients who have got intrinsic sphincter deficiency, and they are the ones who probably will fail the initial treatment, and they need to have urodynamics, and basically then you decide what you need to do. And that's probably a more subspecialty issue. So you can take care of nearly 70% of the cases who have got stress urinary incontinence. Now, the next component is the storage component. Storage component is very simple. Either the storage is less, which means the woman has got urgency, she wants to go all the time, she's not holding more than 150, 200 mils of urine. So if you have a storage problem, then the storage problem is either sensory or motor. So if it's sensory, that means you're getting urgency all the time. I want to go, I want to go, I want to go, I want to go. But actually, if you do some bladder testing on them, the bladder capacity is 450 ml. There is no muscular detrusor contractions, okay? So that's called sensory urgency. And then you have motor urgency, which is your classical urge incontinence, overactive bladder syndrome. So if you have a woman who has got sensory urgency or motor urgency, the first 4 months should be devoted to timed voiding, so empty the bladder every 2 to 3 hours, vaginal estrogen if you're menopausal, reduce tea, coffee, Coca-Cola, all the aerated drinks. Make sure you're not diabetic. And you can give a trial of anticholinergic, doesn't matter, whichever you give, for 4 months only. And you review the patient in 4 months' time. If the patient gets better, you can continue that treatment for 2 years, and you will find a 65 to 70% recovery rate. Sensory urgency is classically postmenopausal in nature. However, you can get sensory urgency in women who get recurrent urinary tract infections. Recurrent means more than 3 per year, proven on microbiology. Such women, if possible, should have a ultrasound KUB, and if possible, also a cystoscopy, because you might be missing some diagnosis. Long-term prophylactic antibiotics is something that is coming up big time. Professor James Malone-Lee, who I worked with many years ago in the 80s, his team is doing great work on that. But I think the important part to understand is storage disorders versus basically sphincteric disorders. Keep it simple: storage disorders, sensory urgency, motor urgency. Sphincteric disorders, stress urinary incontinence, make sure you do physiotherapy for 4 months, give vaginal estrogen. And I think that will simply take care of between 60 and 70% of patients that come to you. You don't need to do complicated urodynamics. Just do a midstream urine sample, take a good history, make sure you examine them properly, make sure they haven't got a genital prolapse. And that is Urogynecology 101. Very simple, basic, don't have to have anything complicated.
Thank you so much, sir. Thank you for the wonderful message and clear-cut message that preventive urogynecology has a much better role as compared to treatment. So thank you so much, sir. So
Thank
see you
you.
soon.
Thank you very much for
So,
having me.
yeah. Thank you,
And
Arjun people. Yeah.
well,
Yeah.
my thanks
Thank
to
you, sir.
Dr.
So,
Sunita Tandulwadkar and FOGSI and all the best.
thank you, sir.